Good morning, ladies and gentlemen, and Mike, thank you for the introduction. As Mike indicated, I am the president of the Pinnacle Group. My name is Chris Ream. Pinnacle Group is a health services consulting and management company out of Denver, Colorado, and we work with about 250 hospital systems across the country, specifically on their physician-hospital alignment strategies and management of the physician-hospital relationships. We're here to talk to you today about catalyzing digital health and how that can boost provider revenue and reduce a health system's business risk. What we're going to cover are the 5 roadblocks we've identified and actually watched derail health system strategies. We're going to share with you how to overcome these obstacles and actually use that solution to achieve a competitive advantage. Then we're going to look at immediate solutions to manage risk and drive revenue that we've created here with our partners that we just talked about. And then we'll talk a little bit about the key to long-term value creation. So what are those challenges and roadblocks I just mentioned? Well, the first is CMS and OIG errors and omissions audit failures and penalties associated with those failures. Many of you have heard of the government activities, Operation Restore Trust, and a variety of other solutions, but there are a lot of dollars that are flowing out for unanticipated consequences of the actions and billing practices and false claims. HIPAA and high-tech audit failures. This has really increased dramatically in prominence because of recent changes to the Healthcare Insurance Portability and Accountability Act, particularly as it relates to protection of protected health information. We're seeing some significant revenue declines in health systems due to slowed transitions in EMR. And I think most of us are familiar with the revenue and expense surprises that are associated with newly acquired physician practices. Then finally, physician dissatisfaction. It's rampant and it's not a good thing. Unhappy physicians make for unhappy administrators. Let's talk a little bit about the compliance risk as it relates to errors and omissions and false claims. The RACs are probably the most recent and most prominent of approaches. It's called the Regulatory Affairs Certification, and there's public and private auditors that are looking at up to 1% of the claims for healthcare providers. What we found is that the majority of practices are actually below the OIG threshold of tolerance for accuracy in coding. 90% basically is the threshold that they use when they do their auditing, and basically if the documentation matches 90% to the coding that's actually on the claim that they're looking at, they consider it to be appropriate. Well, on average, 96 of 100 claims reviewed resulted in a take-back in 2011. I think the scary thing here is with the OIG work plan for 2013, they're taking a really hard look at medical necessity. And the challenge we face here, particularly at the health system level, is that 100% of the hospital revenue streams associated with a non-medically necessary service of a physician are now at risk. And that is a pretty significant concern, particularly even if you're not in an employment scenario, but you're just at the mercy of the appropriate decision making of a physician. So you have a lot of risk associated with the revenue streams, and God forbid that actually ends up being penalties. And multiple systems over the years have paid over $100 million back to the government in addition to penalties. And in 2011, $2 billion in takebacks. And again, we're not even talking about the penalty side of it. We're all very well aware that there are treble damage capabilities in the legislature to exacerbate the challenges that we have with these types of failures. So how much unidentified risk is there with a newly acquired physician practice? We take on a 20-doctor practice. How much is that going to impact our health system? So let's talk about the compliance risk with HIPAA. The majority of private practices, just like with the errors and omissions, they're not in compliance. In 2011, according to the Department of Health and Human Services, 67% of the investigations led to enforcement. And this is new because, as most of you know, HIPAA did not have a lot of teeth tied to it for the privacy failures. It does now. And what is the cost of noncompliance? Well, The first is public humiliation. For those systems or organizations that end up in a situation where they are found to be in violation of HIPAA, they actually have to print the nature of the violation and the scope of the violation in a public forum. And that has to be there for, I think, upwards of 2 weeks. And for something that used to not have any teeth tied to it, we've now seen multiple enforcements of over $1 million, and we actually had the highest one recently of about 4.3 million. And these aren't organizations that we're unfamiliar with. Signet, 4.3 million, CVS Caremark, 2.5 million, Blue Cross Blue Shield of Tennessee, and Mass General had million plus penalties assigned. And I think one of the keys to the enforcements is that these were not nobody was really harmed necessarily by the breaches. It was just a matter that their policies and procedures were not deemed to have been sufficient to protect the public interests. So this is actually pretty disconcerting, because there's not necessarily a harm here, and the government is actually assessing some pretty heavy fines. It's also difficult and expensive to comply. The study from the American College of Healthcare Executives and American College of Medical Practice Executives indicated that they estimated about $15 million for the average health system to comply with HIPAA. And they drilled down a little bit on a per physician basis and found it was to be $15,000 per physician. So we have those costs and those risks associated with the errors and omissions and privacy. And then we have this painful transition to EHR. I think the very few would argue that the requirement of both the industry and the government is going to have physicians and health systems moved into a digital environment or an electronic medical record environment. And really it's all but legislatively mandated by the end of 2014. This process takes, according to the Medical Group Management Association and Health Leaders Media, this process takes upwards from 3 months to upwards of 3 years to deploy. And I think one of the important things to note is that there's a recognized decrease in physician productivity during this transition time, and particularly during the transition time, because we're managing these dual workflows. You have this paper environment where you're pulling charts and you're doing paper scripts, and then you also are learning your electronic medical record, and you're referencing back and forth between the electronic and the paper environments, and you have these dual workflows that are really pressing the practice and not only reducing productivity, but also increasing the cost of support staff, et cetera, in the office. Now, as you look at it from the health system's perspective, where they're actually, say they've employed a group of physicians or brought on a practice, and they're trying to move them into that digital environment, it's even bigger challenge, because they have both the lost revenue streams for the physician practice itself, and they also have the lost revenue streams for the physician-directed services, such as admissions or diagnostic tests that are ordered, et cetera. And then we look at, according to a study by Health Leaders Media, that 70% of hospital executives plan to employ or contract with more physicians in the next 3 years. 56% of the physician placements were in hospital-owned practices back in 2011. And in fact, earlier this year, there was a study that by Health Leaders Media that said 39% of health system CEOs project EMR to be their largest expenditure. It's going to be their largest expenditure. They have these 2 layers of revenue that they're having to manage, one of which is in an arena that they're not particularly familiar, which is in the physician practice environment. So this is a really dynamic and difficult challenge for a health system. And I'm going to talk a little bit shortly about what that actually means. Physicians are the engine of the health system. They direct all of the revenue that gets created in the health system, or at least the vast lion's share of it, majority of it. But we pulled data from the Medical Group Management Association 2010 Physician and Production and Compensation Survey, and also the American Hawkins Associates 2010 Survey of Physician Inpatient and Outpatient Revenue. Those 2 studies are actually they actually surveyed numerous physician practices across the country. The MGMA is in the tens of thousands. The Merritt Hawkins Associates is in the hundreds of hospitals, and they basically aggregated information to assess how much revenue is generated on average by a physician in a variety of different environments. But it's done by specialty. We just took the average here. But the practice revenue on average is $610,000 per physician. Facility revenue that's directed by a physician is $1.5 million. And on a per encounter basis, the practice revenue is $125, and the facility revenue per encounter is $315. So about $440 per encounter per patient visit is basically generated by a physician. That's what kind of a driver this is. So $2.1 million a year and $180,000 per month. A very significant revenue line to manage and monitor. So what happens if we slow down that EHR transition by 6 months and we're down productivity, say 20% for that 6-month period? $330,000 is the actual nut. And that's a big number, but when you consider that a medical staff of 300 to 500 physicians is not uncommon, those numbers get really, really scary. So let's talk about physician dissatisfaction. So we have brought on physicians. We're pushing them into this digital environment, and most of us know how much physicians love transition to EHR. Most of us have moved our physicians to productivity-based compensation plans to make sure that they continue maintaining that productivity so they can drive the hospital volume and drive revenue for the practice. But we're forcing them into the electronic medical record, and that's reducing their productivity by 20%. And they have all these other burdens associated with their practice and correct coding and all the other challenges. And so what's that producing is a very significant growing trend of dissatisfaction among physicians. I think this is pretty well documented. Most of us are familiar with it. But just a couple of stats, 70% of physicians, according to the American College of Physician Executives, are at least moderately frustrated with the burdens imposed by their hospital employers. And I think it's important that they actually, because they are employed by the hospital, that the hospital becomes the target of that frustration. And I think that's actually an important thing to note, because when they're in private practice, they maybe blame the government. They could find somebody else to blame. But when you're their employer, they have you to blame. So it costs $250,000 to replace a physician. So if we don't manage this EHR transition and we don't manage the risk associated with the acquisition of this practice, so these things all kind of stack up on us. We have a $250,000 hole for a physician that left. We may have a $330,000 delay of EHR. And remember, this is our biggest investment for 39% of the healthcare executives. This is our biggest investment of the year. I'm not sure that that's the ROI my board of directors is looking for as a CEO. So these things are piling up. We have the risk that's created by the legacy systems and paper documents. We have all these different disparate systems that we're trying to aggregate. We have dual office workflows that are slowing down our physician practices, and we just have all that resulting lost productivity. And this is falling down to a tremendous amount of income and compliance risk. So what do we do? How do we turn this roadblock into a competitive advantage? Well, hey, guess what? We need to assess and plan. It's cliche, but all of us would not be terribly surprised, or I guess you would be terribly surprised to see how many hospital systems or healthcare organizations have acquired physician practices because strategically it made so much sense. They drove so much volume, and they had to protect that book of business. And they didn't dot I's and cross T's. They didn't look at the front end of it. They didn't look at the workflow and the customer service processes. They didn't see how that practice operated and how moving into the health system would change the way that workflow operated and how that practice functioned. They didn't look at the coding and documentation carefully enough. They didn't realize that those physicians were coding all 99215s and were actually inappropriately billing and weren't documenting sufficiently for the coding levels that they were achieving. All they saw was the dollars that they were driving to the hospital, and they saw that the practice was incredibly profitable. But they didn't look under the hood far enough. Compliance and privacy practices. This is a big issue in small physician practices. They don't see the issues. They don't know. They don't have the exposure to the legislative challenges. It's just they're not as much under the microscope. but they become a part of a multi-million-dollar health system. They're part of that. They become part of that health system, and that's probably the weak link as it relates to privacy and compliance. How easy is it going to be to transition them to an environment where this is something that's very carefully looked at, it's considered very important? If they've discounted it before in order to make the practice run and be efficient, how are we going to make them see it as important? Well, if we look at it and assess and plan and we work on the front end, we can at least have a good plan for transitions. We at least have transparency. We at least know where our weaknesses are, so we actually know at least what we're getting into. So you just can't look at this carefully enough. If you don't have the resources internally, get the resources externally. But this front end work is just absolutely critical. It's just a heightened level of due diligence that we have not been engaging over the course of the last several years as we looked toward physician practice acquisitions. What else can we do? Well, let's accelerate the go digital process. How do we get to a place where all of these different data sets and all these different exposures are in a place where we can see them and we can manage them? Well, if we can get from a paper environment or these legacy systems that we don't have control over that are disaggregated, if we can get to a digital environment where we have a singular location or a singular access point for our data and our historical information, we're going to be in a safer, better place. We're also going to be operating much more efficiently. But we need some planning assistance. We need to have someone. We've scaled back our IT departments. How are we going to bring on 3 or 5, 12 physician practices when our IT departments are already stressed out with the existing load that they have? Do we have the people to train? Does our MSO have the capacity? Or do we need training and implementation assistance? And I would argue that we almost invariably need training and implementation assistance because you need perspective. And you need a third party. You need that perspective for both sides. You need that perspective for somebody can say to a physician practice and to the staff in the physician practice, say, this is how it's done. We've seen it work. We know it works. And there's not the polarization of the interests, the person that's trying to get something done on his side versus the person that's trying to say, I want us to be in this compliant environment. We got to dot all our I's and cross all our T's. Can we get external technology and infrastructure assistance? Is our system slowing down because we're taxing it too much? How much do we make the investments that we needed to? There are a lot of with technology now. We have a lot of virtualization. We have a lot of capabilities to augment existing infrastructure, perhaps even outsource it. Proper planning with expert advice will accelerate the implementation time, and it's going to reduce your risk. So have a plan. It just sounds cliche, I get it, but we need to, if we look at it on the front end, we understand that there's a big amount of risk here and understand that we cannot, it's hard to put too much resources into this. This is one of the most important things we'll do. We are protecting the engine that's driving the volume and driving the value in our health system. So QLogic, NEC, Intel, and Blackball, along with Pinnacle, have kind of aggregated our resources and our capabilities to come up with a solution or a suite of solutions that will actually catalyze this go digital process, that will get you quicker from point A to point B, less painfully from point A to point B, and create more value after you get to point B. We're taking all of the legacy data, whatever format it's in, structured, unstructured, and we are processing that data by getting it into a digital format, OCR. We're processing that data, and we have automated and manual processes to get that data into a structured environment, to meta tag it, to index it such that it is readily available for future data access. And we can store that remotely or in a cloud-based solution. We do it locally for some mission critical data so that it's really, really quickly accessible to the provider at point of care. And we even have the ability to store it or push it into your current EHR solution if your EHR has the capacity to pull in indexed files, etc., without having to scan it in or having to individually move document by document in. So what does it do? It accelerates the transition from these manual processes and paper charts to an electronic environment with automated workflows. So we attack the storage, the retrieval, the workflows. It gets us to a place where we are attacking both the loss in efficiencies and the increase in risk associated with having all these disparate, unstructured data access points. So how do we compare to what's there and what's being used and what's available? Well, of course, there's internal resources that most organizations use, and we've seen this at the individual practice level where Betty is actually scanning every document in and tagging it and putting it onto the patient's chart. We have third-party document management solutions at ImagIN. We both actually have the capacity, and this is not anything extraordinarily new in the industry, but we have processing centers and scanning capabilities to process millions of scans daily. The images have to be analyzed so that they actually can be tagged. Typically, when internal resources are being utilized, it's an individual that's sitting there tagging it and plugging away. The third-party document management solutions, and this is where we really differentiate ourselves. The third-party document management solutions actually mimic the existing paper layout. Typically, maybe they'll barcode and they push it through. But if that paper layout isn't consistent with what you want to use going forward, or isn't consistent with what your go-forward workflow is under the new EMR, it's not very useful, because then the doctor still has to go through at the point of care and look through multiple PDF documents before he can find what he's looking for. Even a very fast system with good OCR capabilities and search capabilities is going to take a long time for that physician to actually find the data and find the document that he's looking for. And we actually in ImagIN can customize and we automate that indexing of an analysis of images, so we can do it much less expensively than what has been available historically. And then, of course, we have custom image storage. We do it hosted or on-site, and actually we recommend a hybrid solution. And the hybrid solution allows for, like, as I indicated earlier, this easy access and quick access to mission-critical data at the point of care. As far as image retrieval, same story. Web, we even have some custom app solutions available for our clients. And then ultimately, we can even transform the data and get it into formats and indexes that actually can be pushed into the EMR that the client's using. So you don't have to use our application for the search and management, but we can put it into your electronic medical record. If you're happy with the document management solution inside of your medical record and the structure of the data in that's certainly something we can do. Or we can do it as a transitional solution where you move it as you need it, but it's again indexed and prepared and ready to be moved and can be moved en masse instead of by document or file. So let's talk about how we sustain these benefits. I mean, this is great. We've accelerated the EHR transition. We saved all this money. We've improved the productivity in our offices. We've met meaningful use requirements. We've actually really stepped it up. And so we have a significant and rapid return on our investment. We even have the ongoing benefit, which is part of this discussion, of just having access and infrastructure so that we have less risk going forward, and then we have better data security and access. But one of the real keys to this is we've taken all of this unstructured data from years ago, and we no longer have a scenario where we have a truncated data set. We have digitized structured data that can go back as far as the documents that we actually scanned. So if we're looking at a scenario where we're trying to evaluate a certain disease or our processes or our treatment protocols for a certain disease, and we have 3 different practices that are in this specialty that manage this disease that have all come on at different times, we have 3 different data sets, all of which are truncated. We can of course pull claims data and things like that. But now that we have this structured data, structured clinical data, we actually have the ability to go back and analyze that data and create additional value. Now, this is not part of the core be-all and end-all, but just think about what the possibilities are when you suddenly, by bringing on a practice, instead of starting new, you have seamless data to the extent that we've indexed it to that level for you and customized the structures to that level for you, you have data that can go across multiple years, even prior to when that practice was acquired. You can even show differences pre and post acquisition of a practice in terms of what your protocols and what your influence as an organization has been. It's a big benefit that we're only starting to scratch the surface on. So let's just kind of go back to what the value of an accelerated transition is here, because I think this is really important to show you how much value can really be created here by working through this process quickly. You have the practice direct benefit of, let's say we've accelerated the process by 1 month. We have the cost savings associated with storage and retrieval. I don't have to go retrieve documents from boxes or whatever else it might be because I had parked them downstairs in my basement. $250 per month per provider. Staff costs. It's generally accepted that you can drop an administrative staff member once you get to e-prescribing, lab interfaces, and those types of things. So we're talking about $2,500 a month there. And then the doctor is going to get back that 20% productivity loss in that month, which is about $10,000. So the direct practice benefit is $12,600 in this situation. And then guess what? He's referring more. He's seeing more patients. He's ordering more diagnostic tests, and we have more admissions. So we have that $25,000 in facility revenue back because that's 20% of what he would refer to us in that month. And so we're talking about $38,000. And this is the low-end case study that we did. We had a 20% reduction in productivity. So $37,000 per month per physician. So what next? As we recognized when we first saw the challenges that health systems were facing in assimilating their physician practices, we saw that we really couldn't provide the solution ourselves, and that's why we sought out partners such as Blackball and NEC and Intel and QLogic. And we have now, I believe, a suite of solutions and partners here that really have such expertise in their respective fields that we have a tried and true option for health systems to really help manage this go digital process and create a ton of value. So as we at Pinnacle is actually will serve as kind of the frontline access point, and we'll do an initial consultation to assess your challenges and opportunities, and then we'll manage the ongoing process. And then as we look at infrastructure and all the other different pieces that we need to bring to bear, certainly some of the other organizations and their representatives will be involved. But we urge you to give us a call at 303-407-0524 and reach out to Mike Stone, who can get the ball rolling and take us to the digital world. I'm glad we were able to spend the time here this afternoon. I look forward to meeting with many of you here at the conference as we spend the next couple of days.